Sure, yeah. My name is Sunjya Schweig, and I am a functional medicine and integrative medicine specialist, board certified in family practice, trained at University of California in Irvine, and did my residency program at the University of San Francisco, Santa Rosa Family Practice Residency Program. And before I even went to medical school, I knew that I wanted to practice integrative medicine, combining Western, allopathic medicine with diet, nutrition, supplements, etc. And so I pursued my path very carefully, and as is, I think, common for a lot of people who do this type of medicine, we end up taking care of patients whose needs are not being met by the mainstream medical system. And so it tends to be pretty complicated cases. And then, in regards to the connection to Lyme disease, it was early on in my career that my wife was actually diagnosed with Lyme disease. And so forced me to kind of enter that rabbit hole, if you will, of trying to figure out, what was going on, what the potential, infections were, and potential treatment paths that were not well described in the mainstream medical system. And so that was a big eye-opening experience for both of us, and really changed my practice in a lot of ways. And for a number of years, I worked in a private clinic in Sonoma County, and then more recently, in the last couple of years, started the California Center for Functional Medicine with my friend and partner, Chris Kresser. And so here we take care of patients of all different types, but again, they do tend to be the more complex. I think it was Mark Hyman that said that when you're a holistic doctor, you take care of patients with a whole list of medical problems. And so that's where we find ourselves. A good percentage of my day is spent dealing with patients with chronic infections, Lyme disease, chronic viral infections, a lot of gastrointestinal issues. And I see that that piece, the gut piece, the gastrointestinal piece, and doing the full spectrum functional medicine piece as being the foundation. And from there, I'm always trying to help people achieve better health, and then hopefully reset them to a certain degree, and then see what role the chronic infections are playing. I mean, it's so whether or not there's an increase in Lyme patients, there's more awareness, I believe. I don't necessarily see a huge increase in my practice, but partly that's just that there's always been a lot. So I think that the need is growing, and I do believe that in large degree we're in the midst of an epidemic. That we know that in the U.S. alone, there's probably at least 300,000 new cases every year of Lyme disease, and those are CDC numbers, which were upgraded from a previous estimate of around 30,000, and they, so the number of 300,000 is, still thought to be possibly conservative. So there might be, a much larger number of new cases every year. And some of those cases, I would say actually, probably more than half of those people, if you get Lyme disease and you're treated with the normal recommended course of 2 to 3 weeks of antibiotics, most of those people go on to be fine and not have long-term symptoms. But we're getting better and better understanding and better data to point to the fact that there is a significant subset of people who do go on to have chronic symptoms. And obviously there's a debate within the medical field whether that's related to a persistent infection, or if that is sort of this post-Lyme disease syndrome or autoimmune activation. That's obviously a big point of contention between the mainstream IDSA medical societies and doctors in practices such as myself, who see patients and treat them for what we think are persistent infections. And in my opinion, I think that that debate is shifting over time. I really do see, I feel like in the last 3 to 4 years that we're kind of over the tipping point of whether or not this thing is real, if you will. And we're still not seeing, unfortunately, we're still not seeing the funding that we need on the administrative or government sides, et cetera. But what we are seeing that has been really encouraging for us is we're seeing a really big upswelling of support from private donors, from foundations. For example, the Bay Area Lyme Foundation here in California. Back east, there's several groups who are really pushing this agenda and pushing for better research and identifying and funding researchers to come up with better answers. Yeah, so in terms of the patients which I see in my practice, there's a spread. Like anything, there's going to be a bell curve I do get some folks who know about our work and know about my work, who have just had a tick bite and who are concerned and they want proper treatment and testing. Those are always really gratifying because it's those early cases when identified properly and treated properly, you can cure them and you can completely prevent them from going on to having any residual problems above their normal baseline. And then on the other end, I get a fair amount of patients who have been diagnosed with persistent vector-borne illnesses, whether Lyme disease or co-infections, and have been through years and years of treatment and maybe have seen some benefit but aren't where they need to be, or maybe they haven't seen a lot of benefit and they're looking for another opinion. Those are, of course, more difficult cases. And then, sort of in the middle is a group of folks who, maybe have, read about it or somebody told them that they think this is what's happening to them. They've had persistent symptoms that, commonly people come in and they've seen 10, 15, 18 doctors at some of the best academic medical institutions and specialists, from cardiologists to neurologists to allergists, internal medicine doctors, and been either given various diagnoses or all too frequently been told that there's nothing wrong with you, like we can't find any problems, and see the psychiatrist, or in the worst case. Those always really frustrate and disappoint me. Frequently they have fairly long list of symptoms that don't really fit into any one basket. It's the interesting thing about these infections and about Lyme disease. So Lyme disease is a spirochete bacteria, and it's similar in some ways, different in other ways, but similar to syphilis, which is also a spirochete bacteria. And these are some of the most ancient bacteria known to mankind, to the universe, the planet, even planet Earth. If you look at the tree of life, the evolution of life on the planet, 3.84 billion years, so 400 million years, 4,000. So at the very top, outer branch are the humans and apes, etc., monkeys. At the very bottom, at the base, are the spirochete bacteria. So they've basically been around forever, and they've co-evolved. They've seen us come up through evolution, and so they really know how our physiology, how our biochemistry, how our biology works, and they're incredibly capable of persisting. And so, it was said about syphilis, to know syphilis is to know all of medicine. And so it's similar with Lyme disease and with these spirochete infections, that they can cause disruption across any body system. And so it's really common to see folks with, complaints that come and go, that span the musculoskeletal to the cardiac to the neurological, and so it can be very difficult to, put into a box and to diagnose if you're not aware of that possibility. Yeah, so it begins with a high level of clinical suspicion. When you have these patients that are have cases that again don't seem to fit into any one box, and span multiple different body systems, symptoms coming and going. So again, the index of suspicion when they arrive is higher, and that's important because again, I think it's actually fairly common to be exposed to some of these pathogens, And so some of the problems with the potential testing is that you could have somebody who's relatively symptom-free who might show some markers positive on the testing. So you really have to put the testing together with the clinical picture. And unfortunately, the tests that we have, so I'll have somebody come in, I'll interview them, talk through their case in detail, and then, come up with some initial recommendations. I do a lot of testing. Again, from the functional medicine side, we'll look at as many different body systems as we can for underlying root cause issues, but then also we'll look for evidence of exposure to some of these infections, whether it's bacteria, parasite, virus. And so, but the testing that we have, unfortunately, is imperfect at best, and not very good at worst. So, and that's a big pain point for us in our practice, and one which I'm optimistic about. I think there's some really exciting things coming down the pipeline of scientific development pipeline. It's so we'll send testing out. We'll do antibody testing. We'll do PCR testing. But again, because of the ability of these bacteria and parasites to evade the immune system, frequently the antibodies are not there when there is an infection, right? So there was actually a good study that came out of the UK, a meta-analysis this past year, that showed that the sensitivity of Lyme disease testing is hovering a little bit above 50%, so almost as good as a flip of a coin, basically. And so the chances, sensitivity, basically the chances that if the test says you don't have the disease, the chances that that test is wrong is around 50%. So the tests miss a lot of people. And so again, it's very important at that point to combine the whole story, understand, what the potential risk is. Has this person had documented tick bites? Have they been in Lyme endemic areas, which unfortunately is many parts of the world, so that's not hard to achieve. There are a couple of newer tests that I've been looking at and using. There's a new test here in the US looking at the urine for the actual antigen of the bacteria in a concentrated form, and that one's more definitive. If positive, there's really nothing else that should make that test positive. There's also some testing in Europe that we've been using in Germany, looking for T-cell activation. And again, the traditional Western blot, ELISA to Western blot, CDC two-tier testing, again, the bacteria is so smart and can evade that frequently those antibodies aren't there when they should be. Yeah, so it's a great question. So when I tell someone I think that you are dealing with some of these chronic infections, and I've gone through several different iterations of this in my career. Right? There's this sort of art to presenting bad news, if you will. Honestly, it's a relief to most people. If you're the 15th doctor they've seen and all the ones ahead of you had said there's nothing wrong with you, when in fact their experience of their body and their life is that, completely unpredictable, symptoms coming and going, various degrees of disability and, frequently having trouble functioning as a normal person. If you tell them, okay, well, actually there is something here which is potentially treatable and which could explain most, if not all, of what you have happening to you, there's certainly, it's a big thing to wrap your head around, but there's also a lot of relief and hope, and that's probably one of my favorite parts of my job is giving people that hope that, there is a direction here, there's a lot of avenues for us to explore. And, again, when I see a new patient and I send them out for testing, it's a lot I ask people to do. There's a lot of tests, all the way from, saliva to stool to urine to blood. And so it's a lot of work, it's a lot of financial, investment for them. And then when I get all those results back, almost, with rare exception, there is a lot of different things which we can put onto our working list to help people with. And I always tell people that, when we look at these tests and we look at, what you're reporting to me about your health, this could be construed as scary or overwhelming or Wow, I had no idea there was so much wrong with me, etc. When I see all that data, I get excited, because here's somebody who has been suffering for years and years with no answers, and now we have a map and we have a roadmap of things to try, things to work on. It's never linear. It's not like I can say, okay, look, we found this, now we're going to treat you and you're going to get better right away. But now what we have is we're starting at point A, and we have a variety of different data that we can use, start interventions, see what happens, and start making ourselves a map to try to walk out of this complex health situation that the patient is in. Yeah, so first phase of treatment for me is always trying to optimize the patient's immune system, and usually that focuses on their gastrointestinal system. So we do comprehensive stool testing with a couple of different labs simultaneously. We always almost always do SIBO breath testing for small intestinal bacterial overgrowth. And at that point, almost always my first intervention is a supportive and also antimicrobial protocol for the gut, for the gastrointestinal system. And along with that, I will address certain key nutrient deficiencies, hormone imbalances, whether thyroid or adrenal. I see those as adrenal dysregulation, thyroid imbalance, as very core pieces. These are all like the legs of the stool, if you will, that if we can get that stool solid and get the person balanced on these core levels, everything else that we're going to try to do is going to be more effective. We're going to quiet down immune system hyperactivity, quiet down inflammation, get their detoxification systems working better, and almost always the person feels better from these protocols without ever directly addressing, what we might think might be some hidden infections lurking in the background. And my take on that is that, we know from this really exciting field on, microbiome, microbiota, the gastrointestinal ecosystem in all of our body, this bacterial microbiota balance that we carry. We know that you can make pretty impressive gains on the immune function, on the ability to control inflammation, and to quiet down autoimmune activation. So those are really key pieces. And with that, dietary intervention is our foundation as well. Yeah, so dietary intervention is really a core piece of helping our patients get better. And our template is what we call a paleo template diet. And what we're looking for really is a couple of key points there. One is to have the patient eating the highest nutrient density diet possible. So getting rid of all the simple sugars, simple carbohydrates, all what we call the white menace, crackers, cookies, chips, pasta, all the foods which make you feel satisfied and full, but have very little benefit in terms of vitamins, nutrients, protein, healthy fats, etc. So number one, increase the nutrient density of the diet. And the other really important foundation of this type of paleo template diet is to remove foods which are triggering and which are causing inflammation. Number 1 and 2 on that list, number 1 has to be gluten. The level of inflammation and autoimmune cross-reactivity and triggering that the gluten grains can cause is always impresses me. And I would really encourage any practitioner and patient, to implement a gluten-free diet immediately and see what benefits happen from that. And in a lot of people, they see significant gains, and they realize upon re-exposure that they can't tolerate those foods. Dairy is another big trigger. Nuts can be a big trigger. Eggs can be a big trigger. So it really requires, and there's a lot of excellent resources on doing an elimination and reintroduction diet. So taking out the most common trigger foods and then reintroducing them one at a time, and seeing how the person does. Yeah, using low-dose naltrexone is definitely a growing part of my practice, and I think at this point, definitely the majority of my patients are either on it or we've tried it, and for some reason, a small percentage of people decide that that's not something they want to be taking. But and it's also, I'm noticing that I'm using it earlier and earlier in the treatment. Previously it was something like I would see the patient, I would talk to them about some options, I would send them out with a bunch of testing, they would come back in a couple of months, we'd go over the results. And particularly with the SIBO, small intestinal bacterial overgrowth, had been using a lot of low-dose naltrexone because of its activity as a pro-motility agent to help with gastrointestinal motility. So these days I do find myself prescribing it earlier, sometimes just at the first visit, and what I'm seeing is that it has there's a lot of overlap in terms of all the conditions we're discussing, whether it's chronic infections, whether it's inflammation in the periphery, whether it's nervous system inflammation, central nervous system inflammation, gastrointestinal disruption, gastrointestinal inflammation, all these things that low-dose naltrexone can help with, and so and these patients who come in are kind of like this, almost this like soup of inflammatory mediators. They're really overloaded with triggers, and they're not able to clear out the toxins, etc. And so any interventions that we can do that help to start lowering that inflammatory load, I find beneficial across almost no matter what is happening for them. So I think that the low-dose naltrexone, in terms of its ability to modulate that inflammation, to kind of reset that autoimmune activation, is really, really helpful. Yeah, I definitely see the psychological improvements. I think the two most common things that people report to me with the low-dose naltrexone is improved energy, and then also just this, again, a sense of vitality that frequently is accompanied by an improvement in cognitive function. And it's sometimes paradoxical because I think that the most common side effect that I see is some sleep disruption, some vivid dreams and maybe restless sleep. Rarely do I find that is so bad that they have to stop the medicine. But so there's this paradox sometimes of maybe feeling like the patient is sleeping more fitfully, but at the same time they have this sense of increased energy and increased vitality. Yeah, so in one sentence, if I was telling another physician whether to consider using low-dose naltrexone, I would recommend it, and I would say that this medicine has the potential to fairly dramatically modulate the immune system and inflammation in a way which is very difficult to achieve through other treatment modalities. Yeah, there's absolutely a denial and a controversy, as well as a rise in the public media in terms of awareness around Lyme disease. And to be very honest with you, it really confuses me. I don't understand it. I don't understand. I went through my medical training through my medical school and my residency, and almost minimal exposure was given to these infections, other than the very mainstream, sort of, you have Lyme disease, you get your bullseye rash and your knee swells up, and you take your 2 weeks of antibiotics and you're fine. And so it really was, and many of us, it happens this way, where it becomes a personal issue, either a friend or a family member, or sometimes a practitioner themselves, forces them to kind of dig in deeper. And so I've read a lot about this, and I think it goes back pretty far in terms of the quote-unquote discovery of Lyme disease here in the United States, in Lyme, Connecticut, was made. The doctor was working on that, still in the field, Alan Steer, and I think it was kind of like a fortuitous or a non-fortuitous thing that he happened to be a rheumatologist. And so this disease got shunted down the rheumatology track, thought to be an inflammatory joint problem with an autoimmune activation component. And whereas I think that if it had been discovered, quote unquote, by an infectious disease doctor, that it would have stayed in that realm and there would be more willingness to look at this as not that unusual. It's not unusual for bacteria to be able to persist. And so from there, I think it just snowballed. I think it became, kind of a war of hubris and of ego, and but to be honest, it's still very, again, confusing that we're still at this level of controversy. And when you spend your day working with these patients and testing them and treating them, it's still, I try to make sure that I'm not, overdiagnosing this. I'm very aggressive about, trying to find laboratory data to back up what we're seeing, if possible, and to, try things judiciously with patients and say, this is an experiment. We're in this together, and we're going to try this treatment and see what happens. And if you're getting better, then we're getting data on that. And if it doesn't help, then we need to regroup and think about what's happening. I do worry sometimes about over-treatment, but nowhere near as much as I worry about people not getting the care and not getting the treatment that they need. Interesting, yeah. So that's important, yeah. And that's again what I was speaking to a minute ago, which is that to not overdiagnose and to not miss other things is a huge challenge, because it is the more you do this work, you realize that an infection with one of these bacteria, whether it's Lyme disease or a co-infection like Babesia, Bartonella, Ehrlichia, viral, chlamydia, pneumoniae, mycoplasma, so there's so many, that these bugs can cause these, complex multi-layered symptom pictures, but you always have to be looking out and making sure you're not missing something. And, so that's where I think that, the combination approach, the Western medicine approach, I've worked very hard in my work to identify specialists, cardiologists, neurologists, allergists, pulmonary doctors, psychiatrists, folks who I can refer the patient to and say, hey, am I missing something here? And have them, do a workup from their angle, and to tell me, okay, basically to rule out other conditions. And there's a lot of discussion also in the media and in the research about Lyme causing a lot of other conditions such as Alzheimer's, Parkinson's, MS, ALS, some major neurological conditions, as well as, being a trigger for intractable depression and anxiety. Anytime I hear something about treatment-resistant depression or treatment-resistant anxiety or treatment-resistant insomnia or, heart palpitations, arrhythmias with no clear diagnosis, etc. So that raises my index of suspicion. But again, in my work, I always try to work, if possible, with other practitioners who can help me to rule out other organic causes or biochemical causes, so that we feel comfortable continuing to work on what we're working on. In our country, and I think in the world, there's this big emphasis put on evidence-based medicine, right? And that's a tricky thing because evidence, there's certainly a lot of scientists out there, researching and writing and providing data on, core hard science pieces, but a lot of the evidence is actually, provided if there's a gain to the pharmaceutical industry, for example, or some medical device company. But the evidence is there for Lyme disease and for persistent infections, and also for low-dose naltrexone. There's some wonderful papers that are out. So the evidence is there, and all it takes is a intellectual curiosity and a willingness to look and to look at those articles. In the case of Lyme disease, there's articles looking at the level of disability that patients diagnosed with persistent Lyme experience, on the same level as people with severe diabetes or congestive heart failure, or even higher at times. There's increasing evidence now showing, a difference, a fingerprint, molecular fingerprint that separates people who maybe get exposed to early Lyme and then recover versus the people who go on to have chronic health issues from it. And so I think that these are all going to be used for better diagnosis and treatment. If you look particularly in the veterinary literature with Lyme, Borrelia infections, there is very, very clear evidence that this bacteria is amazingly able to persist. And, the veterinary models from mice to cats to dogs to horses to monkeys, all show persistence of this infection, even at times after as long as 4 months of antibiotic treatment. And so the veterinary studies are easier to do because, you can autopsy the animal and you can look and see, if there's persistent spirochete infection in the organs. We can't do that with humans. And so, the studies that we've done in humans have tried to look at that, but many of them have been flawed in either duration or the types of treatments they're using. There's some very exciting research coming out in the last few years on persister cells and looking at treatment regimens that might target these persister cells of Borrelia, which seem to be metabolically altered, slowed down, able to, again, evade the treatments that we've been trying to use. And so that's, you'll speak with Dr. Richard Horowitz. He's been very aggressive about implementing some of these protocols in his practice. The core science research is coming out of Johns Hopkins, as well as Northeastern University. Two of the main doctors doing this research is Dr. Ying Zhang and also Dr. Kim Lewis. So again, looking at these persister phenotypes and looking at novel drug regimens, frequently using some of the antibiotics that we've used, either pulsing them or altering the dose regimens, or also using drugs which have historically been used for persister bacteria, like a TB or a leprosy model, medicines such as dapsone, daptomycin, et cetera. Yeah, so obviously, transmission by biting insect has been well documented. There's the clearest known vector is the tick. There also is our case reports of transmission even from biting flies. So that kind of argues a little bit about the duration of tick attachment. It's historically been said, 24, 48 hours or longer. I don't believe that. I believe you can get an infection with Borrelia with a shorter duration tick attachment, as well as possibly from other biting insects. In addition, many of the co-infections can be passed. For example, Bartonella, it can be passed from flea bites or from lice, et cetera, as well as cat scratches, obviously. There's very clear data showing that mothers can pass it to the baby in utero. I don't think that's up for debate. Some people do debate it, but again, I feel like that just, if you look in the research literature, there's many articles and case reports describing this. The question about sexual transmission is a thorny one, and a one that I don't think we have enough evidence for yet. I would not be surprised if it were. Again, these are spirochete bacteria. Syphilis is a spirochete bacteria. It's clearly known that syphilis is a sexually transmitted disease. If Lyme Borrelia is in that spectrum, I don't think it's as good as syphilis at being a sexually transmitted disease. I think there's some things which blunt that a little bit, but it's complicated. We do see this illness clustering in families. It has been shown, for family members to have similar strains of the bacteria on PCR testing and genotyping, and it has been isolated in body fluids such as breast milk as well as semen. So again, the direct connection hasn't been made, but it does seem like there is a smoking gun. Yeah, so in our work, what we try to do is to take as big of a view as possible, to step back and to put as many possible treatment options on the table. And one of the things that fascinates me, the kind of common theme that holds all of this together is to look at this as ecosystem medicine, sort of evolution, how we evolved, where are we at right now, what are all the triggers that are contributing to the person's health picture. And that's where low-dose naltrexone comes in. You know, it has the ability to modulate a lot of the inflammatory pathways, to re-regulate the autoimmune activation which can occur, you know, downshift peripheral and central inflammation. It's the same place where dietary intervention acts, you know, by taking away these triggers, taking away the systemic inflammation, decreasing the autoimmune activation, and you see people getting better. And I would also put onto that, that same spectrum, you know, some of the mind-body work, meditation, yoga, qigong, acupuncture. You know, there's a really wonderful book by a woman named Donna Nakazawa Jackson called The Last Best Cure, in which she talks about her journey through very severe autoimmune illness, where she sort of reached the end of what the Western medical system specialists can offer her, and she spends a really dedicated year focusing on you know, these pieces, the mindfulness piece, meditation, again, yoga, acupuncture, and her description then of the science, the current science around that, and how we can, again, downshift that toxic or inflammatory soup, milieu, all the cytokines and chemokines that we are swimming in. So, so that piece is not to be neglected. And you know, what is exciting for me in some of these things is that you give the locus of control back to the patient. You know, you say to them, okay, we've identified all these things, here's some treatments that I would like to implement, but here's what you can do on your end. And, you know, and all the lifestyle pieces, mindfulness pieces, you know, therapy, dealing with old traumas, you know, so all these, I think that's really exciting.